We have to learn something new. We shouldn't go around imagining that we understand how to manage end of life. We delude ourselves into thinking that we're good at this. We actually aren't, and this is a relatively new undertaking for us.
Hello, I'm Belinda, I'm one of the doctors. I'm going to listen to the chest there. Look, I think we find in ED it is really frustrating and it's distressing for patients and their families when we've got a patient who's clearly at the end point in a terminal illness and nobody's had a meaningful discussion about end-of-life care.
What has happened is that we've got into this sort of pattern of resuscitating anyone and everyone, whether it's in their best interest or not.
We know that CPR in older people in general, but certainly in old frail people, is not of no benefit. Virtually everybody doesn't survive, and if they do survive, they don't leave hospital.
Most of us working in acute care settings, including in intensive care, think we're managing end of life well. But we've run a series of audits that show that actually we do quite badly, not just in intensive care, but in the hospital as a whole.
I see MET calls frequently where no end-of-life decision has been made, despite the fact the patient is on a deteriorating pathway, and no counsel sought as to the patient's wishes, what the family think the patient's wishes are, and what the patient would deem as a good outcome. It's just not discussed.
I guess as junior staff, we often feel like we're left by ourselves and we could do with a lot more consultant support and guidance in this area.
Medicine's had an amazing history, but also peppered with some really stupid things that we've done along the way. And unfortunately, resuscitation could be one of those stories if we don't change the way we approach it.